Hi, Dr. Heeman.
Good morning, Darryl.
Hi. Thank you for coming to our conference. A lot of people are looking forward to your talk because a lot of people are dealing with erectile dysfunction and an interference of sexual pleasure. So I know a lot of people are at the edge of their seats, at the cusp of their computers and laptops, looking forward to whatever help you can share with us today. First off, could you tell us what kind of doctor you are and where you practice?
Certainly. So, first of all, thank you for having me. It's my pleasure to be here, and I hope I can shed some light onto this important topic. I am an assistant professor of urology at the University of Washington, and my subspecialty focus is in male reproductive and sexual health. So, I completed my fellowship there and am back on faculty at the University of Washington, where I focus on male cancer survivorship, and that includes sexual function as well as urinary continence, and then other topics in men's health, such as male infertility.
So you see a lot of guys coming in with concerns about erectile functioning, sexual pleasure, what happens to my ejaculate, will I be happy after I do treatment, if indeed I do treatment? Uh,
Absolutely, that's
yeah.
that's a major focus of my practice.
All right. Would you say that from your conversations with patients, it's a major barrier towards accelerating a pathway to treatment?
I most of the time I see men after they've already been treated. And sometimes they're faced with surprises, things that they hadn't been told prior to their therapy, that they're now confronting and disappointed by. And so sometimes part of my job is kind of to create fixes for quality of life. That's part of the reason I got into this field, that I can really just help with quality of life for men dealing with some of the toughest things they've ever dealt with: loss of sexual function, um, loss of pleasure, like you mentioned, urinary control. And so, it's a more rare time for me to be meeting with a gentleman before their treatment, but certainly that would be a good time to talk about what to expect.
Yeah, and I could hear 1,000 virtual guys behind me saying, "You're right, my doctor really soft played it," or something. And there maybe a dozen or 2 dozen or more, we hope, guys who said, "I knew what I was getting into, but I really didn't really expect it to be like this, and I
Yeah.
wonder when it'll get better." Let's start off, just sort of get everybody in an even playing field. What actually causes disruptions in sexual pleasure and erectile dysfunction? Let's start with surgery, and then you could tell us also what happens around radiation that causes that.
So there are a variety of mechanisms that can impact sexual function in the care of prostate cancer. Um, Namely, with surgery, there's two major, I like to think of it as two major causes. Erections are something that we all think of as something that men should be able to produce any time of day, but in reality, they're very complex and require, perfect blood flow, really good, healthy penile tissue, good testosterone, nerve input to the penis, and freedom from anxiety. So, when one gets treated for prostate cancer, a few of these elements of an erection are all changed. Um, a prostatectomy, for surgery to remove the prostate, um, changes two major elements, and that's the blood flow component and the nerve component. So we know from research that I did during my residency and throughout, the world, a lot of research has shown that um, the nerves surrounding the prostate that help send the message to the penis to get strong blood flow are affected by radical prostatectomy, even in the nerve sparing setting. There's some stretching or compression of the nerves that can occur and can reduce that message to allow the penis to get blood flow. The other component to prostatectomy is a change of the vasculature. We are altering the venous flow, so the flow of blood away from the penis in the pelvis when we remove the prostate, and that can impact erections as well. I think that a component of this that is perhaps largely underlooked or underestimated is the mental component. When a man has had prostate cancer and prostate cancer treatment and a major surgery and kind of all the changes that go along with that, that can certainly create depression, anxiety, just distress, and those impact sexual function. I always like to think of erections or our nervous system as sort of a fight and flight. And when one is experiencing anxiety about performance, it really makes the system as if you're running from a bear. And so you can't get a good erection when you're running from a bear. So the mental component of cancer treatment is I think plays a role as well. And that's really a part of kind of the holistic treatment of the problems that we see after prostate cancer treatment.
I mean, you're right. You probably can't get an erection while running from a bear, but the joke is, but look at the bear. So the idea of disruption to blood flow is sort of not very well understood by patients. I mean, most people are looking at, because it's called nerve sparing surgery, and because surgery sort of means you're going to cut something out. So are you going to cut my nerve bundle, cut my nerves or not? That's sort of like 99% of folks will think that's what I got to watch out for. I want my doctor to be super careful with that. But but around blood flow, both, filling up and releasing, I mean, are there things that a patient could prepare better for surgery, can prepare themselves for surgery in a superior way to, raise the odds in his favor?
Yeah, I think one of the things we do talk about is, is a little bit controversial about whether it's truly effective, but I think there's no harm in it, is sort of prehabilitation. So taking medications like a Viagra, generic type of Viagra, to help kind of pump up the blood flow before surgery, or kind of stimulate that system before surgery. I think that what we know is that men with underlying erectile dysfunction preceding their surgery tend to do worse with outcomes. And so, treating that prior, I think getting good blood flow to the penis before is always helpful.
Was that a bear in your background?
Yes, that is.
We should all run now.
I apologize. This is what we deal with
Yeah. No, that's
telehealth.
okay. It's okay. No, it's almost on perfect cue, though. So let's talk a bit about radiation. Oh, by the way, it's worth saying the nerve bundles that go around the prostate, you tell us, are they similar or different than the nerve bundles that carry information about orgasms?
They are different. So that is one thing that I like to highlight. I'm sorry, Darryl, if you want to pause, we can certainly pause.
No, that's yeah, actually, let's pause. Let's just okay, we're recording. So while we're talking about disruption to nerve bundles from surgery, can you tell us the nerve bundles on the prostate, are they also the nerves that carry information about orgasms to our brain and help us to enjoy sexual pleasure?
Those are actually different. So the sensory nerves to the penis are usually still left intact. And what's important to know is that men can experience orgasm and climax without having an erection. So, that is a direction that we can go. That is sort of one of the least, invasive methods of managing sexual function and pleasure after prostatectomy, is meeting with sex therapists. These are practitioners that are highly skilled in talking with men dealing with cancer survivorship issues. And they can kind of guide couples or men through routes that don't involve getting an erection, but still can involve pleasure.
Yeah, and we've helped many men learn how to have orgasms with the softest and the most flaccid of penises.
Right.
Yeah, and it's really quite interesting. And I mean, one of the strategies is just to, I mean, we encourage people, now's the time to sort of fantasize, think whatever, nobody, whatever can get you off. Nobody could hear what goes on between your ears. If you need accoutrements or clothing, pull the curtains, or share it with your partner or not. But the opportunity to enjoy pleasure still exists to a significant level.
Absolutely.
Yeah. Let's talk about radiation. What actually impedes erectile functioning from radiation?
So the mechanisms are pretty similar, although the time course is a little bit different. So when a man has a radical prostatectomy, the changes to the nerve bundles, the blood vessels to the area take place right away. And so we see the most profound erectile dysfunction and the most profound leakage kind of immediately right after surgery. And then we see things start to recover. Radiation is sort of the opposite. So as a man's going through radiation, he may not perceive any changes to these functions, but radiation works by damaging cells. So it works by damaging DNA in these highly replicating cancer cells. With time, that creates changes to other sort of cells or nerves or vasculature in the area. And so the changes that radiation causes kind of take time to set in. And so we do see issues with erectile function. We do see issues with leakage that kind of come at a later time point, maybe a year, maybe 18 months, et cetera. The mechanism is largely similar. So just injury to those cells in the area, fibrosis around the nerves, damage to those very small, tiny blood vessels that carry the blood to the penis. Those are some of the mechanisms that radiation causes similar changes.
Yeah. And as a way to lead into restoring all this, what everyone's hoping to hear, wants to know, why is it that for some men, these changes, these disruptions, these damage points are more or less permanent, and for some they dissipate over time?
That's a really great question. I think a lot of that has to do with preoperative function. So if a man has had excellent erections, or, a younger man with excellent erections, may be more likely to recover his erections afterwards. Men who have other underlying conditions that, predispose to these things like erectile dysfunction may be less likely to recover. So things like diabetes, high blood pressure, advanced age, these are all risk factors for erectile dysfunction, and those play a role in whether a man can recover or not.
Yeah, and level of testosterone as well.
Sure. And
I
that
mean,
was, when I had talked previously about the elements to an erection. Some of the other more advanced prostate cancer treatments, like hormone therapy to reduce a man's testosterone, that plays a role in sexual function as well.
yeah. And it's worth noting, reduced testosterone usually can happen for older men or for any man, independent of androgen deprivation therapy in the later stage treatments. People just naturally have low testosterone or grow into years where their testosterone is challenged.
True.
Yeah. So, okay, we got guys in our audience that are struggling with this. Whether it's a big struggle or a little struggle, it's nothing that's desirable. It's it's the 1 in a million guy that's going to really get off on, the post-treatment, opportunity to not have an erection and such.
Mm-hmm.
What's on offer for help?
Luckily, this issue of sexual dysfunction after prostatectomy or prostate cancer treatment is one of the areas where we have a really deep toolbox. We have treatments that range from pills to surgery, and so I'll kind of go through those one by one. The pills that I'm describing, first of all, sex therapy, as I mentioned before, non-invasive, talking about how to achieve pleasure without having an erection. That's, one direction. Second is the pills. So these are phosphodiesterase 5 inhibitors, so things like Viagra, Cialis, etc. Um, these work by sort of amplifying the message to the penis. And so they help those nerves carry the message forward to the penis to bring blood flow here. They help maintain, they help kind of the rigidity. And that's the typical area where we try most men. I will say that men who have kind of two hits, meaning something like diabetes and a prostatectomy, tend to not respond super well to those pills, meaning they aren't super effective for men who have underlying erectile dysfunction and then prostate cancer treatment. I find that they don't work as well, but that's okay. We have kind of more options. To amplify the pills, I offer a vacuum erection device, so a VED. This is a cylinder that fits over the penis and by physical suction draws blood into the penis. It comes in conjunction with a ring called a constriction band that fits at the base of the penis. And these things together just sort of amplify a man's natural hydraulics. So that's really what an erection is blood flow in, and that creates sort of trapping of blood, and then that creates rigidity. So by the vacuum device uses suction to draw blood in and then a constriction band to help kind of trap that blood. And that can work with the pills or alone. The pro is that there's really no side effects to using it. The cons are that it can be cumbersome to use. Beyond those therapies, we get into sort of the more advanced treatments. So things like injections. So intracavernosal injections, or ICI, is a very potent way to get an erection to use for sex, and it's used on demand. So these are not injections that are used to kind of cure the baseline ED, but it's something that a man would use every time he wanted to have sex or to get an erection. The medicines come in a variety of mixes. So I use, a single medicine in clinic with a man to sort of test this out. But most people are prescribed a mix of 3 different very powerful vasoactive medications. And these just tell the penis to bring blood here. The onset of the medication is faster than the pills, and it definitely works considerably stronger. Some of the downside is there's usually a cost associated with these shots. They're typically not covered by insurance, but a little goes a long way, and so men can experiment with different dosages. That sort of mix of medications that comes in a shot form has 2 other formulations as well. One that's sort of newer on the market that is not used as frequently, but I have used with my patients, which is a gel formulation. Instead of using a tiny needle to inject into the penis, a man would insert the gel into the urethra, so into the pee tube. This brings that same medication to the penis and helps get an erection. It's also made in a urethral suppository. So it's a small little pellet that a man would put inside his urethra, again, on demand for sex. What I always say about these therapies is that they don't restore the spontaneity of having sex. And for some men and some couples, that's a really big deal. They have enough barriers to having sex. They've got grandkids running around. They've got kids coming by, they've got jobs, and stress to deal with. And so a lot of these barriers, and then to think about having to use a medicine, may not be ideal. And so the real way to restore spontaneous erections for some men is by having a surgery to give a new hydraulic system. So that is a penile implant. And so that is a surgery that's done in the tens of thousands in the United States every year. A lot of men who've had prostate cancer surgery elect to go that route because it is truly restorative. It is truly giving you back those sort of on-demand erections that last as long as you want and are rigid and with the same sensation that you should expect as pre-op.
Let's talk a bit return to the trimix, the injection things.
Hmm.
So the injection typically doesn't hurt, right?
No. Yeah.
Okay.
So that's one of the barriers that I have to overcome with patients is that, it is a very tiny needle. It's the tiniest needle that we have. I do it often in clinic, and I would say 99% of guys say, "Oh, that was it." It's almost entirely painless. The penis is a potential space, meaning it's sort of almost hollow, and so it's not really like a vaccine where you get a shot and it kind of smarts as it goes in. The fluid itself is very a small amount. It doesn't hurt going in. It's just sort of like a little tiny pinprick.
Yeah. And you mentioned Trimix, three different medications
Hmm.
in one shot, so to speak. There's also Bimix and other combinations. And in our support groups, many guys have been asking about, I forget what, I mean, you tell us what the third component is that's sort of an option, or not as, not a deal killer. But some guys are having better experiences with just two of the three
Just the
rather than three.
Bimix.
Yeah. Can you talk a bit
Yeah.
about that?
Yeah, I mean, I think that when we talk about, single agent, double agent, so the single agent usually is Alprostadil. That's what I use in clinic. The benefit to it is that it's shelf stable, so you don't have to refrigerate it. The downside is it can cause a little bit of aching in the penis or even stinging when it's used. And so that's why we mix it in with other medications to sort of reduce the amount of Alprostadil that we have to use. I definitely have sort of experimented with Bimix or Trimix to see, what guys like, because I think the questions that I always ask when I'm treating men in this circumstance are, does the treatment work and do you like it? So you have to really like it to want to use it. It should be fun. This is sex. It should be something that you enjoy and something that works for you.
Mm. And how do you differentiate these chemical intervention, these medications for gay men and heterosexual men, for for anal insertive men who need more strength to get in there?
More rigidity.
Yeah.
Um, I mean, I typically start with Trimix just because I think it's the kind of industry standard. Um, I think it's really important to have very close follow up and kind of be talking with the patient about, is this working for you and do we need to adjust things? I think it's really important to have a good relationship with a compounding pharmacy because those are the specific pharmacies that are typically making these. There are some nationwide compounding pharmacies that are very good and very, they're really aimed at this branch of medicine, sort of men's health. And so um, there are great options out there, and I think it can sometimes just be a trial and error. And that's
Yeah.
usually what I experience.
And just since you mentioned compounding pharmacies, it's worth just, what's the difference between CVS and Walgreens and a compounding pharmacy?
Yeah, so CVS, Walgreens, obviously many we've all picked up medications there. A compounding pharmacy is a specific separate pharmacy that mixes medications that may not be, FDA approved or, that are sort of off label. They make the mixes of the penile injections. They make mixes of, different hormone therapies. This is where I might often get, male fertility drugs or female fertility drugs. So they're different, and they are specific to this area.
Yeah. So let's return. Typically, you would see, like, I mean, for just simplicity, like three unique cohorts of guys. You got guys who live alone who are masturbating for the most part. You got
Mhm.
guys who are seeking or involved with heterosexual relationships, meaning they're having a vaginal insertive sex. You've got guys that are gay or bisexual men, or men who just enjoy having sex with men on the down low, and they're
Mhm.
relative to prostate cancer treatment, the concern is around anal insertive sex. For the straight, gay, bi, and MSM guys men who seeking sex, enjoy
Mhm.
sex with other men, they're all they're all at least thinking about oral sex, being able to have their penis in someone else's mouth or in someone else's hand. How do you differentiate? Do you differentiate, and how varieties of treatments and interventions around all of these different these guys with different sexual goals and pleasure-seeking goals?
I mean, I think that is part of what makes my job really rewarding is kind of identifying those goals and having these conversations with men. Um, People ask me all the time, why am I a woman? Or is it hard being a woman in a field of male sexual health? And I think this specific area is exactly why it's a little bit easier because that is part of being, a caring person and a caring practitioner is identifying the goals, identifying what's going to work, really reading the room, reading the patient, reading the couple, reading the man, um, and being honest about goals, being honest about, what is going to work and what's not going to work. Men who are dating, for instance, are they going to, I talk with my patients about this. Are you going to carry around intracavernosal injections? That may be challenging. What are the ways we can get around this? For couples who travel a lot, how are they going to, be able to carry these medications on the plane? So it's really getting to know people. It's really kind of um, asking, what are your goals? How are you seeing yourself in this sexual role? And that's, how we find the right therapy.
Yeah. Are there things, let's talk, I mean, so there are medications, there's surgery, which is to say, not surgery, but an implant that sort of puts in a hydraulic kind of thing going on,
Mhm.
which works. The metal spring that you could sort of insert and bend your penis, nobody's doing that anymore, or what?
So that is a different type of penile implant, and I do talk with certain groups of men about this. That's called a semi-rigid or a malleable penile prosthesis, and it's sort of what we kind of coin as the rods. Um, in the UK, in other countries, that is done 95% of the time, but in the US, we tend to do more of the inflatable penile prosthesis. So that is like I mentioned, a hydraulic system that sort of allows a man to use a small pump that's inserted inside. Really conspicuously, it's inconspicuous. It is a very minimally invasive surgery, um, and it allows a man to sort of pump up the penis when he wants an erection, and then release it down when he doesn't. Um, the malleable penile prosthesis is a good option for some men. Some men with very limited hand function. Some men who maybe don't necessarily need as rigid of an erection. And I do talk about it with men. I have done that surgery, a fair amount. I think it just, again, kind of goes back to finding the goals and what's going to work best for each man individually.
Yeah, and good that you mentioned limited hand functioning. I mean, there are men, as we all get older, there are other things than cancer that get in the way of things.
Sure.
And one of them is uh, what's it called when a hand shakes? Not Parkinson's
Oh, a
necessarily.
tremor.
Tremor. Yeah, I mean, people have a tremor, and people have weakness either as a
Hmm.
consequence of that or just general weakness in their hands and fingers. Um, it, I mean, I'm not a particularly old guy, but I've started to notice, like
Yeah,
difficulty, you know, uh, these interfere with some of the interventions that are on offer. And,
sure.
a good doctor takes that into consideration.
Yeah.
What about I mean, and I could hear my virtual audience asking about complementary stuff, black
Mm.
cohash, or I don't know, whatever you could get at the grocery store, or nutraceutical, or from some fake doctor, online,
Yeah.
go ahead.
There's kind of two categories of that. There are the nutraceuticals, so these are sort of pills, supplements, etc. Um, and then there are procedures that are experimental. And so first I'll kind of talk about the former. The nutraceuticals, sort of supplements, do not have great data, is the bottom line. They are not highly regulated. They may be, you don't really know exactly what you're getting bottle to bottle. And so I can't recommend them. There are no, scientific studies that prove that these things help. And I think because we do have a good kind of armamentarium of what we can use for ED, or, other elements of sexual dysfunction after prostatectomy, I can't recommend them. The other sort of side of the experimental therapies are procedures. So a lot of things have come to market or come, onto the radar of sexual medicine doctors like myself. And I'll just list a few of them. So number one, shockwave therapy for the penis. Low intensity shockwave therapy has been studied and is a therapy that we in urology use for things like kidney stones, but at higher doses. So this has been studied as sort of a regenerative therapy. Similarly, things like stem cell injections, PRP or platelet enriched plasma injections. These are sort of the other, things that have been marketed as restorative. The goal of all of these therapies is to amplify the stem cells in the penis so you can sort of regenerate blood tissue, so vascular tissue in the penis. I would say that there is some data that is showing the potential to help some men, especially in the area of shockwave. There is some data that is showing that you may improve erections somewhat. I talk about this in a very cautionary way because I think that the data out there is limited. I know that the data out there is limited. And in our society guidelines, this is still, thought of as in a very experimental therapy. These are the areas where practitioners who are not urologists often are performing these treatments that are not paid for by insurance, and they can be extremely costly. And some of these practitioners I do think are predatory, and men who are seeking, restoration and they want their sex life back after prostate cancer surgery are, desperate. And I understand why men might seek that out because it offers a promise, but the science behind it is very limited. And I am an open thinker. And so, I read the things about it. I want to talk about it as, I answer questions about it for patients. But I do think that a lot of the people who are offering these are don't have the patient's necessarily best interest in mind.
Yeah, I mean, we've tried to learn more about shockwave treatment, and we find the company, the main company behind that, whose name I don't want to mention, really doesn't have the pay. I mean, they're just not really, patient focused at all,
Yeah.
and that's a shame because, as you say, there may be evidence around it. I mean, there's, some hope around that, but
Yeah.
you can't endorse companies or treatments that don't care about patients.
Right.
Yeah.
And the research is ongoing, we're in the middle currently of our annual Sexual Medicine Society meeting, and there's still research being done in these areas. And I think once we have, more of a firm grasp on how to apply these technologies, that they will be available to patients. But, offering it right up front for cash is potentially only benefiting someone's bottom line.
Yeah. In the time we have remaining, let's do two things. One, Well, let's definitely talk about how to help men on androgen deprivation therapy if we can. And two, why hasn't there been, outside of these things we just mentioned, it doesn't, actually, let's cover this first and then get into ADT. Why hasn't there been, really big leaps in new novel treatments or new treatments or durable treatments or really good things for patients around restoring sexual pleasure and erectile dysfunction? And that's predicated by the idea, is it that what we've got now actually isn't half bad?
Yeah, I mean, I think that's one reason. I think we have kind of a large amount of options. Some men may not see it that way, but we do have really good options that work. And another reason why it's challenging to study is just because the population of men is really diverse. As you mentioned, men are dealing with different sort of relationship statuses, different age. It's a huge population of men who, there's projections that there will be over 4.5 million prostate cancer survivors in the US alone by 2026. So there's just a huge amount of men, which offers opportunity to study these things. But, identifying a specific protocol, how to do some of these more experimental therapies like obtaining plasma, blood, getting a blood draw, spinning it down, and then re-injecting into the penis. Researchers have their own way of doing things, so kind of standardizing a therapy can be challenging, especially when the pharmaceutical companies are not involved, because they are more highly regulated, and so that allows us to kind of standardize and do very kind of appropriate randomized controlled trials.
Yeah. What for men on androgen deprivation therapy? Is there anything available for them?
This is an area of oncology that has evolved over time. I know that back even when I started training and kind of, hearing about all the trials on androgen deprivation therapy, the goal was really to strip men of their testosterone and for long periods of time potentially. And the longer we've, been able to study the therapy, the longer we've known that of some of the other side effects of ADT. So, cognitive changes, mental health changes, et cetera, that come along with ADT. And we're realizing that maybe we should minimize rather than just maximizing. And so there are regimens that men can potentially be on where it's intermittently dosed, only if a PSA is rising, are they going to get a Lupron shot or, an ADT shot. And that is really a good area of discussion with my oncology colleagues and, either urologic oncologist or medical oncologist. I think, some of the strategies for men who have low T and who are, have just locally confined prostate cancer, we know more and more that supplementing testosterone is likely safe, and I definitely am a proponent of that. I think it's been controversial for a long time, but the data is speaking for itself that giving men who have treated prostate cancer, low risk or moderate risk disease, testosterone supplementation is probably safe.
Yeah. And actually, our audience probably is savvy as to the dosing and stuff. I mean, what do you suggest? I mean, at what level do you think testosterone level is safe? Like 160, 200, 250, what?
In terms of needing to supplement,
Yeah.
if a man is under 250, 300 nanograms per deciliter, that's what we would consider testosterone deficiency by the Endocrine Society and American Urologic Association guidelines.
Right. And the dangers of having low testosterone, under 250, under 300, there are cardiac issues and muscle mass, which, if it's diminished, then leads to fatigue, which leads to obesity, perhaps leads to obesity, and, which returns to cardiac and diabetes. And also, it's a constellation, for lack of a better phrase, it starts a shitstorm of stuff that, people just don't want to get involved in. But the repair sounds so scary. Testosterone is going to, start up my prostate cancer, when now we're seeing it probably won't if it's managed properly.
Right, right. I think, a lot of, we see these pendulum swings of media coverage on different treatments, and, in the early 2000s, testosterone was coming as this sort of panacea. So a lot of guys were asking to be put on testosterone. The testosterone pharmaceutical company was sort of blowing up. And then there was this sort of a backlash of, not great research, actually really poor research that showed the dangers of testosterone, and that got a lot of media coverage. Really, the good data shows that with close monitoring, prostate cancer survivors or men who've been treated for prostate cancer are safe, especially if it's, lower risk disease. And that's my, that's in my research, what I, not in my personal research, but in my reading of the literature, that's my takeaway.
Yeah. So all of this is in service to getting the glands, the head of the penis, where you want it to be, so that you can enjoy sexual pleasure for everybody. That's sort of like a pithy way to put it, or not. What do you think?
The gland specifically, yes and no. But yes, the penis, the nerves, having some restoration of comfort level with sex and pleasure from sex, is definitely a goal that I see in most men. But like I said, everyone is a little bit different.
Yeah, and comfort level. It's the orgasm's important, but it's the part of the enjoyment of that orgasm is to be chill enough, to be relaxed enough to enjoy the orgasm,
Sure.
to not worry about a bear,
Right.
male or female bear. It occurred to me, maybe that was presumption to suggest that the bear actually had a penis. It could easily be a female bear chasing you. Equally as dangerous, I imagine, bear wise, at least bear to human wise. The idea that ejaculate is off the table post surgery, post radiation for everybody, that ain't coming back.
Certainly after prostate cancer surgery. So after prostatectomy, yeah. And that is sort of an unfortunate side effect that I see sometimes that was not explained to patients ahead of time. Yes, there's no more ejaculate after a radical prostatectomy. And the reason for that is the vast majority of ejaculate comes from the prostate and the seminal vesicles. And those are all removed during prostate cancer surgery. That does kind of play a role in fertility. I have seen younger guys, or really guys of any age, who are in relationships with potentially younger women. So men in their 40s, 50s, 60s who do desire another biological child. And we have to kind of address that before surgery. So whether that means banking sperm, so ejaculating and kind of banking that before prostatectomy, or doing alternative methods afterwards. So for instance, testicular sperm retrieval afterwards, which can be used for in vitro fertilization, IVF, to have a biological child.
Yeah. And we routinely tell everyone pre-treatment, bank your sperm. If no matter what you're thinking, you can't predict what you're going to desire in the future. And, if it really becomes irrelevant, you'd stop paying the bill, the annual bill,
right.
Or offer it to someone else if you feel generous and, want to see yourself somewhere else or whatever. The idea that anxiety, depression, the basic goals, just disappointment. I mean, rather, we try within our network, we try less, using words like anxiety and depression and, classic psychological terminology, and more concrete, realistic street level stuff like you're disappointed, you're adjusting to something, you're
Right.
screwed, you're feeling like this isn't what you paid for, this isn't what you were told about, bargained for. These all play in as critically as the physical damage that you get. And that's less understood, and good that you started this wonderful conversation with a discussion presenting the idea of the emotional well-being of the guy as critical as the physical well-being of the guy.
Right.
And good that our general medical world has reasonably good interventions for guys who have
Mhm.
damaged erectile functioning.
Right,
You know,
right.
Mm.
Yeah, I think the one of the best benefits of being a prostate cancer survivor is just that there are so many. So groups like can attend to, lectures like this, support groups on a local level, um, and certainly kind of for physicians to evaluate a man's social structure and, support system is really important. Men as they age have higher rates of mental health, issues. And um, obviously being a cancer survivor can amplify that. And so it's, it's really important to address. It's really important to get men looped in with support, whether it's a good therapist, whether it's a doctor, whether it's, a friend who is going through the same thing. Really, really important at kind of the holistic care.
Yeah. And now's not the time for patients, for men to be shy, particularly
Right.
around these consults. Whatever it takes to share your goals, your life, now's the time to just do it. Even if it's like ask the doctor if you could whisper in their ear,
Mhm.
or send them a text, or
Yeah.
an email, or scribble on a piece of paper, ask them to read it when you leave, perhaps, and try to have, set up conversations after the face to face. One
Right,
of the
right.
beauties of telemedicine is we're learning it's really not bad, which is to say it's actually pretty good, you know.
Yeah, I think, I mean, like I said, most of my practice is 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 touching on these sensitive subjects of sexual function, Peyronie's disease, etc. And allowing a man to kind of talk about it from the comfort of his own home, I think is one of the really big benefits to telemedicine in kind of in the sexual medicine arena.
Yeah. Dr. Heeman, thank you for a wonderful and illuminating conversation, and welcome to our conference.
Thank you so much. It's been my pleasure. I hope everyone stays safe and does well.